I'm seeing folks joining from the School of Public Health, some colleagues from our Minnesota Department of Health. This is really, really cool. So thank you all for joining. My name is Andrea Perez Michaela. I use she, her pronouns or ella in Spanish, and I'm the program manager for diversity, equity, and inclusion at the School of Public Health. Before we begin, I first want to acknowledge that the School of Public Health at the University of Minnesota Twin Cities is built within the traditional homelands of the Dakota people. Minnesota comes from the Dakota name for this region, Minnesota Makoche, which loosely translates to the land where the waters reflect the skies. It is important to acknowledge the peoples on whose land we live in, learn, and work as we seek to improve and strengthen our relations with our tribal nations. We also acknowledge that words are not enough. We must ensure that our institution provides support, resources, and programs that increase access to all aspects of higher education for our American Indian students, staff, faculty, and community members. I also want to point out that closed captioning is available today. You can access that by using the icon at the bottom right. I don't know if I'm doing right or left this time, but of your screen. You can also reach out to Sarah Harris, who is providing our tech support today via the chat to ask questions about accessibility. We'll monitor the chat for questions as well as share links to our evaluation and information about future justice and public health events. Now, as you all remember, the Justice and Public Health series was started last year as part of the School of Public Health's commitment to justice and anti-racism. We have been hosting monthly events with local and national experts around topics of public health, and today marks the first event of this school year. The speakers and presentations in the series help to ground us in theory and practice, as well as complement the classroom learning that our students experience. We also hope that today's discussion is part of a broader change happening outside of School of Public Health. If you're interested in staying abreast of other justice and public health events, please be sure to fill out our event evaluation after this and check the box to receive notifications about upcoming events. You can also visit our DEI website at any time, and this event will be recorded and will be available to view on our website for about 180 days. Now, I want to welcome our speaker for today. We have joining us Dr. Carlos Rodriguez-Diaz. He's an associate professor and vice chair of the Department of Prevention and Community Health at the George Washington University Milken Institute School of Public Health. He is also the founding director of the Gil Levovic Center for Community Health in the Caribbean and Latin America at George Washington University School of Public Health. Dr. Carlos Rodriguez-Diaz is a community health scientist with nearly 2 decades of experience practicing public health and conducting community-centered research in Puerto Rico, North and South America, and the Caribbean region. His work has focused on health equity through actions on the social determinants of health, with special attention to Latino communities, sexual and gender minority populations, and people affected by HIV. His research and scholarship have led to coverage in well-known national and international media sources and major research publications and conferences. Dr. Rodriguez-Diaz completed postdoctoral training in HIV and global health research, a PhD in public health with a major in community health, and an MPH in health education. He has also completed postgraduate training in health policy, human rights, and health diplomacy. Please join me in welcoming Dr. Carlos Rodriguez-Diaz.
Muchas gracias, Andrea. Thank you, Andrea. It is my pleasure to be here, and I am particularly proud to be presenting today in Minnesota with local public health leaders, with academics, scholars, and some other members of our Latino communities. I can also see some of my colleagues and students here from GW who I share the information for this event too, so I'm very proud that you have joined. Thank you. And thank you also for the opportunity to speak on Latino health as we commemorate the Hispanic Latino Heritage Month. It is my pleasure. And on the side, Andrea, I'm very happy that we get to work on this together. Andrea mentioned what I will, we have known each other for probably 15 years. And I'm very proud that we get to do this work together in an area that we are very passionate about. So I'm going to share my screen. I have a few slides to share with you. As you will see, my slides have a lot of images. Most of them have been developed by Latino artists, and I have some pictures, including members of the communities that I work with, and they have consented to for me to share these images with you. In terms of structure of the presentation, we have agreed to have at least, probably half an hour of me sharing with you a presentation, which is basically my experience in conducting public health work with Latino populations. And then we will have time for Q&As, and I would love to hear from you and perhaps the work that you're doing and how aligned it is with some of the ideas that I'll be proposing today. You can use a chat, and we will check the questions during the Q&A session. So I would not be able to see your questions or comments during the presentation. But with that said, let me share with you the objectives that I have for today. First, I will describe the theoretical frameworks that inform my anti-racist and anti-colonial public health work. I will illustrate some public health inequities that are affecting Latinx populations. And finally, I will provide some case studies of interventions that I've been able to collaborate with to disrupt systems and improve public health efforts for Latino populations. And I want to start by acknowledging my position and who I am and why I'm doing the work that I am doing. And this is an exercise that I invite all of you to do as you approach different issues in life in general, because we all have a different set of experiences that inform who we are and how is that we bring our experiences to the table. In public health and the public health work that I do recognize my privilege as a Puerto Rican, Latino, in the continental US, working from DC, in an institution of higher education, supported to do the work that I do. I also acknowledge that I have identities that are stigmatized and that have experienced discrimination over time, including my identity as a Latino, or as a gay man, or even as a Puerto Rican, or maybe a middle-aged adult gay man who might be perceived by other people in X or Y way. So we are not only the identities that we have identified for ourselves, but also how we are perceived by others. And those intersections and interactions often influence the work that we do. And my invitation is to embrace those who are your privilege, so you can disrupt that privilege that you have, and also acknowledge that we use these intersectional experiences to interact with other people and the work that we do. As a framework for the work that I do and my understanding of public health, I have always used a social justice approach, because this approach argues that public health, the work that we do, is primarily a socially generated effort. And that is a collective responsibility to achieve better goals in our communities. I also want to share how I understand health inequities, health disparities, and health equity. And I do this, many of you are in the public health field, and perhaps these are definitions that you know. But if you have looked at the public health literature over time, you have seen different ways of approaching and what health equities are, what health equity is, and how health inequities and health disparities are differentiated. And that's important because in our work in public health, we expect to see some health disparities, because we have different groups with different experiences that will have different health outcomes. But that's different from health inequities, that are those differences that are created by the environment and the conditions that we create as societies. After all, what we are aiming with public health efforts is to achieve health equity. And that means the absence of systemic disparities or inequities caused by social determinants of health. And why the attention on social aspects? Because when we look at what determines our health, around 40% is defined by our socioeconomic experiences, social determinants of health, like education, employment, having a support system, access to wealth. And the narrative of social determinants has become more popular over the last 10 to 15 years. But the truth is that this narrative is not new to public health. It's just that right now we are paying attention after paying attention to other areas that certainly are important for improving health outcomes, but are not the root cause of the differences that we see in the health outcomes among very different groups. And this image, perhaps you've seen it a couple of times and has been edited over the last, I don't know, maybe it has 7 years now, to show equality, equity. And the truth is that I like this image because of that reality check that it gave us. How we have some resources and we tend to aim for equality, but equality means that the people who have resources are getting more resources. With equity, we provide more resources to those who need more. As shown here in reality, often those who have the resources tend to gain more and more resources. There has been a narrative on working on liberation, and liberation meaning removing the structural barriers, in this case, defense. But we have to reimagine, how do we want public health efforts to contribute to social justice and achieving equity for everybody, not only for certain groups or not only with certain resources. And that's my invitation today as we continue in this presentation and our conversation later. And I was invited to talk about Latino health, but who are the Hispanics, Latinos, Latinas, Latinx in the United States? Well, perhaps we will have different answers to this. Even the use of some terms here like Hispanics and Latinos are inherited based on a racist system to classify people that speak certain language or that have certain heritage. Well, I invite you to consider using labels, if you have to, that are owned by the communities that you're working with. Currently, we are using Latinos or Latinas, Latinx more often than Hispanics. However, that have changed over time, and you may work with some Hispanic Latino groups that self-identify as Hispanics or Latinos or as both. And then my invitation is to consider using however your communities or patients refers to. More recently, with the use of Latinos, Latina, Latinx, has come this last terminology, the use of Latino or Latinx, with the X as a way of promoting gender neutrality. But we have to be careful with the use of Latinx in the current narrative. It is a term that it's been mostly used by scholars and academics and certain circles. There is a survey that was conducted not too long ago that reflected that many Latinos, Latinas are not using Latinx as a way of self-identifying. And we don't know if this change in the way we are reflecting diversity within our community is going to stick. And we don't need to know. I mean, languages change over time. And I am not sure if that's what we're seeing now, but I'm embracing the fact that we are facilitating a conversation to that allows for diversity within our community. Now, using Latinx is often a way of trying to be gender neutral, but gender neutrality is not equal as gender inclusivity. Sometimes women who prefer to identify as Latina have made a decision of using Latina because it comes with a power, it comes with another framework that is not visible when we use Latino or Latinx. Sometimes we use we've seen the use of Latinx when referring to transgender people. But transgender people are not always using gender neutral terminology. Some transgender Latinas embrace their transgender identity and their Latina identity. So Latinx actually erase some of the experiences or identities that might be important for a group. My invitation again is to use the label or way identity that the community prefer. Also consider that using labels is not always needed. If you are working with a group of Latinos from a specific region, a specific country, you can check if they prefer to be called, let's say, Mexicans or Puerto Ricans. Also, remember that using these labels is political. And it could also be a way of colonizing language. The use of Latinx or an X after the N, we are making that up. We are making that sound up because we are not using a vowel, which is more traditional in the use of Spanish language. And I've been learning with some colleagues that study indigenous languages, particularly Aztec language, that the X and the pronunciation of the X is different in their lexicon. So, and it sounds like a vowel. So perhaps there is a look of, colonizing, but also embracing some identities. My point, this is a current discussion that I invite you to be part of, be responsive to the way communities are self-identifying, and let's see where we go. If you want more information, there is on the use of Latinx, there is a fantastic paper by my colleague Ana Maria del Rio Gonzalez. It was published in the American Journal of Public Health. It's open access, so here's the title in blue. I invite you to look at it, and she goes deeper in what I have mentioned in the last few minutes. But talking about Latino communities, I want to provide an intro. I don't want to make assumptions that we know of which group are we talking about. And this is data from a recent survey by the Pew Research Center. In the first graph, you can see how the Latino population has been growing in the United States. These are numbers in million. And over the last 40 years, we have seen a significant increase of people who self-identify as Hispanic or Latinos in the US. Also, the identity of being Hispanic or Latinos varies among Latino groups. So here you can see who self-identify as Hispanic and who is not self-identifying as Hispanic based on, sorry, oops, and I haven't changed this, my apologies. This is a graph showing the increase in Latino populations. And here I was starting to talk about who self-identify as Hispanic and who is not self-identifying as Hispanic based on where they were born. So these are the foreign born. These are people who migrated to the United States, second generation, third generation, fourth generation. And as you can see, there is an increase of people who will self-identify in another way that is not Hispanic. There are many whys this is happening. I am not currently studying this, but based on my experience in the work with Latino communities here in the Mid-Atlantic, there is a combination of stigma that they are trying to protect from, associated with self-identifying as Hispanic. And there is also the opportunity to self-identify as a mix of race and ethnicities, and not only as one group. And in terms of the distribution of Hispanic Latino populations in the US, there is a concentration in the Southwest. And of course, this is in part due to the fact that some of this land was part of Mexico. And eventually we have seen more migration from South Central America to the United States. And they tend to stay in states that welcome them, or as we are seeing more recently, unfortunately, they are forcibly moved to other states in the Northeast. The migration to Florida is also historically, we have identified migration of Cubans and other Latino Hispanics groups from the Caribbean to Florida. There was a significant influx of Puerto Ricans in 2017, sorry, after the impact of Hurricane Maria, and they are mostly living here in Central Florida. And we have historic migrations of Puerto Ricans to the Northeast and to Chicago after the 1960s. And now we have the migration, the returning migration, some people moving back to Puerto Rico. And we have seen some similar trends with other Latino Hispanic groups. An important point that I would like to make is that even though we speak of a group of people, we are not a homogeneous group similar to other racial and ethnic groups. So it's very difficult to describe a whole population when we ignoring, sorry, the fact that there's so many differences that define our experience. And those differences also impact health. Let me give you some examples. For example, Latinos in general in the continental US has the highest uninsured insurance rate when compared with any other racial or ethnic group. But within the Latino communities, half of all the undocumented immigrants are uninsured. Documented immigrants, depending on where they are, have different rates of uninsurance. There is a fear of deportation that mostly affect those who are undocumented. And of course, even within the Latino population, not only is a matter of from where you're from, is the conditions under which you came to the United States and stay here in the United States. And lastly, health outcomes of undocumented Latinos are worsened than those that have been documented for Latinos who are documented. When we look at Hispanics in comparison to non-Hispanics whites and other groups, you will see that there is a difference in the prevalence of chronic diseases. And even among the 10 leading causes of death, there are significant differences, particularly caused by diabetes and chronic liver disease and cirrhosis, sorry. And these trends haven't changed over the last decade. And there is a Latino paradox that helps to explain how is that we see the distribution of certain diseases, but at the same time, how when we compare Latinos with other groups, we see less people dying of those conditions. And that is being explained by the fact that Latino populations are younger when compared to other racial and ethnic groups in the continental US. Another disparity in the area that I do most of my work is in HIV. The Hispanic Latinos only represent 16% of the populations in the US, but it represents 30% of all the new HIV cases reported in 1 year. So you can see here a clear disproportion of HIV incidence among Latinos. And I look at the data of HIV incidence in Minneapolis, Minnesota, and 42% of the new infections were reported among Black African-American populations. 32% were white, and 15% were Hispanic and Latinos. However, this is proportion. You may think like, well, that's the Hispanic Latino represent the ethnic racial group with the least new infections. However, Latinos in Minneapolis represent only 9.6% of all the population, but are overrepresented among those who are being affected by HIV. So these disparities can be, I'm using deliberately the terminology health disparity because it's a distribution of a disease based on race and ethnicity. However, this is a health inequity because it's systematic. We saw how in the United States, Hispanic Latinos are overrepresented among those who are infected with HIV. And if we zoom in to many jurisdictions, we will see the same pattern. And this is an example for Minneapolis, Minnesota. And as a Puerto Rican, I also zoom in to the experiences of Puerto Ricans living in Puerto Rico. And when we look at HIV, Puerto Rico is one of the jurisdictions where most of the new HIV infections are identified. And that's why it is one of the 57 geographical areas that have been prioritized in the first phase of ending the HIV epidemic initiative. In Puerto Rico, the prevalence of HIV among adults is nearly 1.1%. And there's some groups that are disproportionately affected, like sexual minority men, with a prevalence of 7.3%. We currently have biomedical strategies for HIV prevention, like pre-exposure prophylaxis. However, Puerto Rico has the lowest PrEP uptake in the United States. So you can see there a clear disparity with Puerto Rico being one of the territories where most of the HIV infections are reported in the United States. But at the same time, one of the new mechanisms for HIV prevention has the lowest uptake. So there are some structural barriers that help explain in this that I will illustrate in a minute. I also want to emphasize as we move to examples of intervention that in public health, we have a problem of where we are intervening and how we see public health actions. These are three areas in which traditionally we create, test, and implement interventions. And over time, we have paid a lot of attention to individual interventions, like let's increase knowledge about certain subjects, or let's increase skills so people can do something. That's great, but people can know and people can have the ability, but if there are no conditions so they can actually enact what they have learned or have skills for, we are not providing everything that is needed. We need to do more structural level intervention, like changing laws and policies. Otherwise, the narrative of social determinants of health is going to stay in describing the problems and not moving into action. So I will provide you with some examples of how we can combine strategies so we can not only provide support to the individuals and the communities, but also create the conditions so those individuals and communities can improve their health outcome. I also want to acknowledge that I take a critical look at the understanding of communities or groups in general, because we are not all equals. The same way in our racial or ethnic groups, we are not all experiencing that identity in the same way. Not all communities are experiencing their conditions in the same way, because there are structural political factors that impact directly the way a community can respond, even when the resources are available. So my invitation in that narrative is to consider when a community is in fact being resilient or when the community is resisting. Because with community resilience, we are assuming that there's some resources that the community can use in order to improve whatever the negative action or factors are, so they can improve their status or health outcomes. But often communities are depleted, they don't have resources, and they're abandoned. However, they thrive, or at least they survive. But surviving is not an option. So that community basically, they are resisting whatever is that is happening. And this sits very close to home as in the narrative of post-natural events. Often the discourse is on the resilience of the communities. But we have to be careful because communities abandoned to their own means is not resilient. Those communities are resistant to a system that have abandoned and are created basically a system to fail. So now with that background, I'm going to show you 3 case studies over the next 7 to 10 minutes. And I will focus on 3 areas: natural events and disasters, HIV prevention and care, and of course, a recent topic in public health, how to handle a pandemic. So first, I want to mention natural disasters, and I will use as an example my lived experience with Hurricane Maria in Puerto Rico in 2017. I was living in Puerto Rico. I still get emotional what the experience was, but as a reminder, this was a hurricane category 5 that hit Puerto Rico just 2 weeks after we had another hurricane, major hurricane, impacting Puerto Rico. So Puerto Rico was extremely vulnerable from the environmental perspective with flooding, and of course, how that affected the general infrastructure in the island. But in fact, I call Maria the perfect storm, not only by the environmental characteristics, but also because affected Puerto Rico during a man-made disaster in which the socioeconomic conditions in Puerto Rico, based on austerity measures imposed by the United States, created an enormous vulnerability for Puerto Ricans and for Puerto Rico to respond to a natural event. So I conducted research in the aftermath of Hurricane Maria, and my work focused on the perception of Puerto Ricans to their response. Because now we have data that Puerto Rico, Florida, and Texas were impacted by hurricanes within the same month. However, the response to Florida and Texas was significantly better than in Puerto Rico. And Puerto Ricans identify or experience that response as second-class citizens and perceive that there was a racist action, not providing the same resources to a jurisdiction that contribute as an equal to FEMA and to other resources that should have been in place to prevent the disaster that happened after the hurricane. That work has also inspired my contribution to the theoretical work in public health. And this is a contribution that I've been working with some mentees and colleagues, trying to understand colonialism as a social determinant of health. And as you can see here, we are acknowledging the experiences based on race and how we move from a state of colonization to decolonization, and all the different factors that are influenced by that colonial experience that we have been using Puerto Rico as a case, but we know that this is also the experience of other colonized groups and countries in the world. In the response to Hurricane Maria, we were working, sorry, oh, my apologies. Something happened here. Okay, sorry. In the response to Hurricane Maria, we were working with community-based organizations in Puerto Rico. Right before Hurricane Irma, we were conducting a survey with transgender communities, and we were surveying and visiting transgender men and women in Puerto Rico. So we had their addresses, we knew where they were living, and we stopped the project that we had that was mostly focused on HIV and STI prevention. And we started providing care to the trans community. And it was the trans community working with the trans community, and we did a fundraising to provide more resources. And it was beautiful to see a community supporting their own community. Unfortunately, that's a model that we continue to need in Puerto Rico. Just last week, Puerto Rico was hit again by a hurricane. In this case, was a hurricane category 1, Hurricane Fiona, with that left historic flooding in the island, particularly in highly vulnerable communities in the southwest, south, and central area of Puerto Rico. And I'm sharing here an example of, again, community responding to the disaster. And this is a picture from Casa Pueblo, which is a community-led initiative in the center of the island in Adjuntas, Puerto Rico. And they're doing many things, but one of their main projects is using solar energy as the main source of energy for their work and their community. And currently, this picture that you see here are solar panels that they have installed, and it is providing for people to go and charge their electronics. They have now internet in the area as well, so students are going and connecting to the internet so they can take courses or complete their homeworks. And it's a totally community-centered initiative. And in fact, the government often just make things harder for them. However, it's thriving, and they're doing the best they can to support their community. Now I'm going to provide an example of work with the transgender community in Puerto Rico, particularly to increase access to primary care. And just as background, we have been conducting research with the trans community for over 15 years. And when I say we, is my collaborators, but also community partners. And we have identified that healthcare providers are not competent to provide LGBT health services. It is not part of their training. It is not part of their continuing medical education or professional education. About half of the providers are not competent in providing HIV care. And that is important because unfortunately, HIV continues to disproportionately affect LGBT populations, particularly trans individuals. And trans individuals continue to document how discrimination is a significant barrier for them to engage in care. And just a few years ago, I was with Ivana, who's here in the picture, and other members of the trans community in Puerto Rico, brainstorming to write a grant for NIH because we wanted to move from pilot testing and intervention to have the RCT to test the efficacy of this intervention. And as we were brainstorming, Ivana told me, Carlos, you know what the problem here is. We don't need to continue assessing the issues and engaging the community to make an interpretation of the findings and then spend 3 years trying to figure it out if something works or not. We need action. We don't need this kind of grants. And to me, it was an aha moment. I was actively listening, and what I was listening is, we don't need another one. We don't need an NIH grant. We need money to intervene, to move to action. So we did, and we applied for a grant together to the Elton John AIDS Foundation. And with the community, we created Proyecto Somos. That if we translate into in English, is like We Are project. That really doesn't capture the meaning, as Somos in this context was more of a belonging, like we are part of this. And this intervention, excuse me, had two arms. One was capacity building for primary healthcare providers, and the second was a group level intervention with trans people to build stigma management skills. As you can see here, this is a classic combined strategy in which we're working with the system, changing the capacity of the providers to provide care, and working with the community so they have better skills to engage in a system that historically has stigmatized trans identities. And we needed to work with them together because we can provide resources to the trans community, but if we don't change the system, it's like doing nothing. So we implemented the project. We also look for partners. In this case, we work with the AIDS Education and Training Center that allow us to provide continuing education to healthcare providers. And that was a hook to bring them to the intervention. And we implemented the program. We had 3 cycles, and a total of 30 transgender women participated in the educational interventions. And here's some pictures of the different groups and the facilitators. We had staff, and some of my students were part of the implementation of the project. It was phenomenal. And we provided training to over 500 primary healthcare providers in Puerto Rico. The model worked. So I was working with one of my mentees who's in the School of Pharmacy at the University of Puerto Rico. And he said, well, you know, I heard from the trans community when you were presenting, this was in a community forum, that a significant barrier is having pharmacists not knowing enough about the transgender care that is needed as part of their primary care. And then they are becoming another barrier because they are either not providing the medication because there is an incongruency between the sex assigned at birth and the identity of the person, or others are simply saying, this is not a medication that is prescribed for you for this particular indication. So long story short, we studied the readiness of pharmacists to provide transgender care. We were working with the transgender community on this assessment, and we developed an educational intervention to provide the pharmacist knowledge to provide care for transgender patients. All this has been published, and in fact, Kyle, who is leading these efforts in the School of Medicine, and the team, we received an award as best practice for pharmaceutical training as part of the American Association of Pharmacy. So it's quite neat. And now moving to my third and last example, I'm going to mention COVID. Since 2020, when the pandemic started to affect significantly different communities in the United States, we started seeing how it was not necessarily a pandemic that would affect everybody in the same way. We started seeing the disparities that we have historically seen in public health, in which stigmatized or minoritized populations are disproportionately affected. And that was the case of COVID and the number of cases that we were seeing in people of color. I had no idea what was going on. I'll be totally honest. I have never done research related to any kind of COVID before. And if you were to ask me in February 2020, March 2020, when the first few cases were identified in the United States, if I were to do work related to COVID, I would laugh and say, no, I don't know anything about COVID. But being unable to contribute and do more, as I'm usually doing on regular basis with my communities, I felt that the knowledge that we have gained in terms of health disparities and health inequities with minoritized population could help in the response to the pandemic. So fortunately, I was able to work with all these phenomenal scientists that are listed here. And we embarked in a fantastic journey in which we integrated data from different resources with the limitations that we had early in the pandemic when in some states and jurisdictions, race and ethnicity was not even being captured when cases were reported. And we were able to document the rates of COVID cases and COVID deaths among Latinos. We used different sources of information, and we divided the continental US in 4 quadrants. And we acknowledged that at the beginning of the pandemic, we were seeing many cases, mostly in the coast. And then we started seeing a trend on how the pandemic started to go inline. So in terms of the rates of COVID-19 cases, in the Northeast and in the Midwest regions of the United States, the cases were higher among counties that had higher proportion of Latinos. And the cases were greater in Latino counties where there were greater proportion of monolingual Spanish speakers, lower unemployment rates, and less social distancing. What this means is that monolingual Latinos had less access to preventive information because even for the CDC, it took months to have their information in Spanish. And many states and jurisdictions were not facilitating information in Spanish. Second, the lower unemployment rates means that more people remain working during the first few months of the pandemic. So those of us who had the pleasure and the privilege of staying at home to basically save ourselves had a lower rate of COVID, but Latinos remain working. This is the case of meatpacking companies in the Midwest, and also the overrepresentation of Latinos in frontline workers. And less social distancing, we were able to capture this by the use of cell phones. And this, our hypothesis is that we have more multi-generational households among Latinos. And in many households, some people had to leave to go and work, and then will affect or transmit the virus to those who were staying at home. And that increased the risks for infection. And we did something similar with COVID deaths. We identify more COVID deaths among Latinos in Midwestern Latino counties, and in Latino counties with crowded living conditions, elevated air pollution, and employment. Again, these indicators are similar to what I mentioned for COVID cases. On one hand, crowded living conditions is associated with, yes, more houses, but also more people per houses. So it's concentration within the community and within the households. And elevated air pollution shouldn't surprise us, and it didn't surprise us, unfortunately, when we were analyzing data, because we have an issue with environmental justice. Minoritized communities often live in places that have the highest rates of air pollution in the United States. And employment, again, was associated both with COVID cases and COVID deaths. We also studied COVID-19 in sexual and gender minority populations because we were already conducting research with this population. And we stopped most of research activities, but we stayed in communication with them, particularly with those who were able to connect via electronic means, particularly Zoom and other platforms for communication. And we did this work because we have already documented that sexual and gender minorities are disproportionately affected by several conditions that will increase their likelihood of having worse outcomes if they were to get infected with COVID-19. So we did a couple of interesting projects. These are the first two that we published, and we were working with Latino sexual minority men. And the initial study was to address their sexual practices and sexual networking, but we just started talking about COVID and how COVID was affecting their sexual practices. And they were making good decisions. So for example, we titled the first paper after a quote from a participant that said, let's hook up. This participant was talking with other partners over Grindr, which is a hookup app. And he shared with us how he was talking a lot with this other person. And it was a way of staying connected and feeling supported and feeling that there was another person out there to stay in touch, but they were not engaging in sexual practices because they didn't want to increase their risk for COVID infection. So they agreed to hook up after the pandemic. And then we also saw different experiences among Latinos based on their behaviors, psychosocial experiences, and medical experiences. And we also saw community-led initiatives As I mentioned, there were not too many resources available in Spanish, less in Spanish for the LGBT community. So we partnered with health educators and our team based in Puerto Rico. And we worked with local artists who were also unemployed and needed to get some work going. So we supported local artists that developed materials that then we added to our website. In this case, here, the artist illustrated the use of PrEP, pre-exposure prophylaxis for HIV prevention in Puerto Rico. And this was the image we used to explain how people could continue or discontinue the use of PrEP based on their sexual practices or perceived risks during the pandemic. And I'm going to stop now. I probably talked more than I expected, but I want to end by saying that that narrative that we've heard, that we are all in this together in public health, come on, that's not true. We are not on this together. We are experiencing public health and health issues in a different way. And we need to dismantle those historically oppressive systems that have colonial antecedents. And we have to do it, replacing those models with collaborations, with partnerships. And with that, I end the presentation. I apologize for talking for so long, but I hope this was useful to you. And I am now open to your questions and comments. Thank you.
Thank you, Dr. Rodriguez-Diaz. We definitely appreciate your time this afternoon and thoroughly enjoyed your presentation. I particularly appreciated your distinction at the beginning between health disparities and health inequities, to really be able to understand that disparities on their own don't necessarily mean that they're inequitable. It's more so when you're adding that structural and systemic determinant to the inequity itself. So I really appreciated that visual. We do have a couple of questions, so I will kind of field them to you as quickly as I can. The first question, I think more so related to your distinction between, Hispanic, Latino, Latina, Latinx. Some folks commented how they've noticed recently, either from conversations with people in the Latin American community, how the use of the word Latine is also in play. So I wanted to just get your thoughts on that word as well.
Sorry, I was muted. Thank you. And I forgot to mention Latine. I've seen the use of Latine in a similar way as Latinx with the X, more often being used by Spanish speakers. So it is the same that I described for Latinx with an X. That's the same conversation we're having with the use of Latine with E when we're talking in Spanish. But again, I think is a way of how the language is morphing, is changing. And we are the generation who's seeing that change.
And I do want to add the caveat when it comes to gender inclusive language, that there is a difference between English and Spanish. And for those of you who studied Spanish maybe in high school, you remember that every single word in Spanish has either an A or O, or most of them have an A or O ending, which makes the word quote unquote feminine or masculine. So I think that the conversation is also about the linguistic ability of being a gender inclusive term, in addition to being gender inclusive on its own. So because even in Spanish, when you use the word for everyone, which is todos, it's the quote unquote masculine form. So, there's also kind of like the feminist movement going in and saying, well, todos, I'm a woman, that todos doesn't apply to me. Why aren't we using todas, which is the feminine word, to be more inclusive? So I think that there's the linguistic conversation now also with the gender inclusivity as well, which I think makes it in the Spanish language a little bit more difficult to maybe come to a consensus than how it's been in the English language.
And briefly, I want to shout out to my colleague Ana Maria del Rio Gonzalez, whose paper I cited in my presentation. I see that she's connected and attending this session. So Ana Maria, muchas gracias. I appreciate, and as you can see, your work is giving us food for thought. Thank you for your contribution and for inspiring my work.
And I shared the link to the publication that you mentioned her in. Another
Awesome.
question related to the hurricane. How do you think the social political has shifted since 2017, and how do you think the current response is different? Do you feel the US response is significantly better?
No, I just think that the attitude is different. I mean, we're working with well, at least the presidents are different, but the system is the same. So we use patches to thrive, well, just to survive Maria. And now we're doing the same thing. We are using patches. Since Maria, or before, we knew that the Jones Act, for example, was a challenge. Jones Act prohibit the use of any mode of transportation, marine transportation, that is not a US flag to basically track to Puerto Rico. And during Maria, that was a problem because we could have gotten aid from other countries other than the United States, but it was not allowed because of the Jones Act. And just with Fiona, I think it was yesterday or the day before, we have a shortage of diesel in Puerto Rico. And there was a boat, ship from the Marshall Island that was ready to give diesel to in Puerto Rico, but they couldn't do it because of the Jones Act. So the government, it was yesterday, decided to give a waive on the Jones Act. That's an example of how things are not changing, because if you see that something is systematically causing a problem, that is a structural issue, you have to remove, you have to amend, or you have to make changes. So you don't have to wait for a waiver so things can actually work.
Thank you, Carlos. We have one more question, but I do want to acknowledge that we're at time. So if folks need to leave the Zoom session and or go to your next event, feel free to do so. The last question, did the US make the investment in infrastructure to mitigate the impact of the current hurricane season?
Sorry, I was muted. So the US committed the money, several $billions to support the recovery and change certain infrastructures in Puerto Rico after Hurricane Maria. But very little, very few millions of those billions have been actually used in Puerto Rico, in part due to bureaucracy, and that's challenging how the communities and different sectors could recover after Hurricane Maria. And that's why there was an increased vulnerability in Puerto Rico when Hurricane Fiona hit.
We just had one question trickle in, one related to where the funding for Proyecto Somos came from.
Yes. Yeah.
And also if you can share a little bit about the type of training they received and whether their views and practices changed after the training.
Yeah, thank you. So the funding came from the Elton John AIDS Foundation. They don't fund research, they fund intervention. So that was phenomenal. It was not the same kind of money in terms of quantity that we could have gotten from NIH, but it was what we needed to do what we did. In terms of the training, it started with in-person training, 4 different modules, kind of an introduction to transgender health, followed by mental health in the transgender communities, then physical health and primary care, and lastly, welcoming and diverse environment for the trans community. So changing the environment in the clinics or in the services. And then, but over time, we also provided webinars and that increased the participation. We only assessed, in terms of evaluation, we only have data impact evaluation, so pre-post. We don't have really data to say this was sustained over time. Perhaps it's time for us to revisit and try to do some work in that area. But we were only able to do impact evaluation with the resources that we had. I can tell that services change, and the best indicator for me is that there are more people from the trans communities in Puerto Rico who are engaged in primary care.
Thank you so much. Well, again, we appreciate everyone's time in joining us this afternoon. My colleagues, Charles and Sarah, have shared in the chat additional resources if you would like to join our October event. And you can also reach out to us at the DI office if you have any additional questions for us or for Dr. Carlos Rodriguez-Diaz. We're happy to share them with him as well. So thank you all, and thank you to our speaker today. Muchísimas gracias. We really appreciate it.
Thanks for the opportunity. I appreciate it. Gracias.
Yep, of course.